My name is Dr. Kehne Moeller. I'm an orthopedic surgeon in Snellville, Georgia. I work out of Eastside Medical Center. I'm here to talk about knee replacements. Ever since October of 2008, we've been fortunate to have the Joint and Spine Pavilion at Eastside Medical Center open for business, for patient care. It is a dedicated unit for neurosurgical and orthopedic patients, back surgery, total joint replacement. The beauty of the unit is it's self-contained, its own nursing staff, administrative staff, cafeteria, physical therapy, all dedicated to one unit for the care of this particular group of patients. We've been very pleased with the results to date. I wanted to talk to you today about knees and knee replacements. When we see a patient with knee pain, there are several reasons why people present to the office. Younger people can have problems with runner's knee, which is kneecap pain, can have knee injuries, which include ligaments and cartilage problems. Older people can have arthritis. We're actually now seeing a lot of patients who are younger than we used to see, even under age 55 or even 50, who have arthritic knees. When we look at a knee, an orthopedist thinks of a knee as having three joints. So there's the inside joint, the outside joint, the medial and lateral compartment, and those are the joints that you walk on. The third joint is the kneecap joint. This kneecap has been flipped down, but in a person's knee, the kneecap moves up and down the front of the knee between 2 and 2.5 inches every time you get up out of a chair, every time we walk up and down stairs. So kneecap pain is actually the most common reason that we will see patients with knee pain. When we start talking about arthritis, if the arthritis is the weight-bearing part of the knee, medial or lateral, that's going to be more difficult to treat than if the problem, including arthritis, is the kneecap joint. So most people with kneecap joint pain, including arthritis, we can treat them without surgery. That includes medication, anti-inflammatory medicine. It includes injections, steroid injections, also viscosupplementation, synthetic joint fluid. That includes Synvisc, Supartz, Hyalgan, Euflexo, Orthovisc, all the different companies who make the synthetic joint fluid products. Those definitely have a role in treating people with kneecap pain or kneecap arthritis when there's wear and tear. As I said, when the damage is more down in the weight-bearing area, lateral or medial, it's harder to make the pain go away. So the initial treatment for a patient with knee arthritis is anti-inflammatory medication, and that includes literally 100 different arthritis drugs. It's not unusual to need more than 1 or 2 to get the drug that works, doesn't give you side effects, is well tolerated. Second option sometimes is an injection, and that includes, again, the steroid or synthetic joint fluid. But as I said, that's usually less effective when there's a weight-bearing joint problem. Once the bone rubs on bone, we call that bone-on-bone arthritis. Oftentimes, you go to the third option, which is a total knee replacement. Patients ask about unilateral knees or unicondylar knee replacements. The philosophy of that is that you just replace the lateral or just replace the medial part of the knee. The ideal patient for that is one who has severe damage to one side. The other side and even the kneecap joint would be pristine. Most of the patients we see have involvement of all three joints, so both the inside, outside, and the kneecap joint. When we talk about a knee replacement, I tell my patients that there are many companies that make knee replacements, and I compare them to having a Ford, Chevy, and a Dodge truck. They all work. So each surgeon has an individual preference. Usually they have a reason why they use the knee they use. Any knee nowadays, when put in correctly, should work, meaning pain relief is the goal of total knee replacement. every company has also taken steps to try to make their knees last longer. There are companies who have modified the metal in the knee itself. There are companies who have tried to make the plastic stronger. There are companies that have made the plastic move a little. There are companies who make the plastic have dimples, so when the knee moves, it rotates into a little dimple. The knee I use is called a rotating bearing, and what that means, every knee replacement is going to have these basic two parts. So we make bone cuts that remove the ends of the bone. This is the tibia, this is the femur, so it would be standing like this. So the bone cuts are made very precisely to make the knee alignment appropriate. Metal is on the resurfacing, so metal replaces the top of the tibia, metal replaces the end of the femur. What makes knees different is the plastic. A fixed bearing component means this plastic piece snaps into the tibia, locks in place, and when the knee is put back together, the knee then moves like this. So that's a fixed bearing component. This knee happens to be a rotating bearing. So I like the concept of this. When we put the knee in, it rotates. Now, does it rotate like this? No, it rotates some. The philosophy behind that is that it tries to reproduce the normal mechanics of the knee, and more importantly, is it tries to minimize the wear on the plastic. So you're seeing now advertisements on TV about the knee that lasts 30 years. The latest statistics on a rotating bearing are that 20 years after surgery, 97% of these plastic bearings are still fine. So the point is, a knee that goes in well not only should provide short-term relief, but these knees should last you essentially a lifetime. What I tell patients when they're considering a knee replacement is you don't operate on x-rays. The x-rays help us make the diagnosis, but we really are not good predicting who hurts or who doesn't based on an x-ray alone. So the reason to consider surgery is for pain relief. It's just that simple. If the pain is affecting activities of daily living, if it's affecting nighttime, which is a very common reason to have surgery, then it's time to consider a knee replacement. It literally can change your life. In terms of, patient education, what to expect from a knee replacement, knee replacement patients usually are admitted the day of surgery. Surgery is done general anesthesia or spinal anesthesia. We've been using a femoral nerve block. An anesthesiologist injects medication into your thigh to make your leg go numb. We've been doing that for about 3 years now. It has provided wonderful relief in the right patient. So initially, pain control can be dramatically improved by using a femoral nerve block. The surgery itself takes anywhere from less than an hour up to maybe a couple of hours, depending on how the complexity of the case. We are allowed 3 days in the hospital, and that usually is spent day one just making sure the patient's comfortable, pain control. We use a PCA pump, which is patient-controlled anesthesia. We oftentimes get patients up even the day of surgery to get them up, get them moving. Some doctors, including me, like the use of a CPM machine, a machine that constantly keeps the knee moving. In the short run, that seems to be beneficial. Physical therapy begins at least a couple times a day for mobility, transfer training to get in and out of bed, and then walking. We start with a walker. I tell patients they'll be on a walker anywhere from a few days up to a few weeks. But I'd say the average is probably on a walker for a couple of weeks, and then it's a cane. And a cane is in the opposite hand of the surgical knee. Opposite hand, it's done for safety. Let the patient walk. It does take about 30% of the pressure off your knee, but it's a total knee replacement. You can weight bear pretty much as quick as you want to. The purpose of the walker, the purpose of the cane, is to make ambulation safe. So walker first, cane second, unassisted ambulation, again, as quickly as you're comfortable that you can walk safely. By 6 weeks, patients are walking well, but they'll fatigue. And the last part of the recovery from a knee replacement like most surgeries, is return of stamina or endurance. And that literally can take weeks and even months. By 3 to 4 months, my goal is that a patient's walking 30 minutes a day for exercise, and even in the ensuing months after that, up to a year post-op, patients will describe progress. Strength improves, gait smooths out, stamina improves. And the ultimate goal is not just pain relief, but return to normal activities with literally no symptoms. The ideal outcome is when a patient says they literally forget about their knee. They just are not ever aware of the fact that they've had a knee replacement, and that's our goal. That's what we aim for.